And suffice it to say, there's some terrific videos, and I got to say that having done this for so many years, if we didn't have our overdose videos, which you can see on YouTube just by searching for naloxone and Chicago Recovery Alliance, we would be in trouble, because giving the same information to people over and over again is really draining, and we want people to be able to see this at all times, because to the extent that they educate others around them, of course, they're educated and protected. So we make the DVDs we have, which Greg put together for us, a part of what we distribute to people along with naloxone so they can educate others. And we've been fortunate enough to have the Exchange Works in the UK contribute 3 videos to that, and a program in Barcelona contribute another. So I think you guys probably have that. If not, I can steer you to a disk image file of that, so you can make the DVDs as much as you like. Either way, the message is breathe, and the idea that naloxone is the silver bullet, the only thing that works, is somewhat true as far as medical interventions, but it's really the physical act of supplying oxygen that makes a difference. And I know that in Canada, I've seen some materials that focus on cardiac compressions. I do not understand that, and so I'd strongly encourage the focus on breathing, and that's really the way it's done in most of the world. Chicago Recovery Alliance experiences, as you can see from '96, we had this incredible increase in overdoses. By the way, what caused me to start this is in May of 1996, my colleague John Zeiler, who was one of the founders of Chicago Recovery Alliance with me, died of a heroin overdose. And I'd lost people to heroin overdose in the past, but this was a time when I was thinking in a harm reduction mentality, and so knew at that time there was something to do about it. Just like HIV prevention, disease prevention, it would have been a good idea, all those things, during the hepatitis B epidemics and whatnot, but the status of the atmosphere and the environment and so forth supports a certain amount of motivational factors, and for me that was the biggest one to get started. And so for those first years, physicians and I were developing the program, scared to death we were going to be thrown in jail, and for empowering drug users in and of itself heresy. But we received nothing but positive feedback from people, and a huge contributing factor that's not mentioned in this chart is the Open Society Foundation, Drug Policy Alliance, Linda Smith Center, I think it was called at the time, held I visited there to do some Hep C work, and did dropped off vials of naloxone to Ethan Nadelman and Jean-Paul Grund and Glenn Backus, and they continued to sit in their offices and remind them we should do something. And we ended up having a conference in Seattle, I think it was in '99 or 2000, and that was hugely important. It helped us recognize that we weren't alone, and physically, real viscerally, it made us realize that we were part of a bigger effort. And then we cut all the strings that were restraining us from blowing it out, and did that. And you can see the impact in our opiate overdose mortality in Cook County dropped significantly during that time, and continues to drop. There's Eliza Wheeler in San Francisco is the project manager of the DOPE project. It's an overdose project that's been going on for a number of years. And she gave me these slides because she's involved with some survey efforts that have been published in the MMWR, the Centers for Disease Control weekly newsletter on public health. And as you can see, in 2010, there were 48 programs with 188 sites in 15 states, and then 3 states that had statewide implementation. This statewide implementation is is pretty important. We, as in Illinois, we developed something we call the Opioid Overdose Program Bill, effective January 1st, 2010. And in this bill, medical people are exempted from liability for prescription of naloxone, and lay people are empowered to both train and distribute under that medical provider's license, and recognize and administer naloxone to a third party. So it's really the first time in my awareness that lay people have been in a sense deputized to provide medical care, in this case emergency medical care. You could say something similar has gone on without the formality with epinephrine and allergies, especially with children. But in fact, there is no specific legal, law for that. But there is for this now, and we encourage in states around the U.S. and certainly you all to empower those kind of exemptions in recognition of the preventative effect that they have. I got to say that Chicago Recovery Alliance was largely by itself in doing opioid overdose prevention and naloxone distribution until that law passed and became effective January 1st, 2010. At that point, just about everyone got involved with it. And right now, I mean every harm reduction program, I should say, but right now we're talking about addiction treatment programs, the jail system, correctional system, and hospitals and other clinics getting involved. So people are getting on the bandwagon now as popularity increases, but that law made a big difference. So I encourage looking at it. I'm happy to send you guys what we have. So, this is from the MMWR. Collectively in the United States, this is the kind of impact we've had. The vast majority of this was, I would call, activist-led. In a sense, Chicago Recovery Alliance has received very, very little funding for overdose. It's just one of the things we added to effective HIV prevention. And that's a point I'd like to underscore, is that effective HIV prevention or part of effective HIV prevention with people injecting especially is overdose prevention. In Russia, my colleagues tell me that one of the biggest things attracting people to safer injection programs there, which are somewhat rare and certainly not government supported, is the overdose prevention aspect of it. And I did a presentation in Vienna at the last International AIDS Conference. After trying for many years to bring that point home on anecdotal experience level, they accepted a presentation on that, and with some colleagues was able to stress just how critical not ignoring the #1 cause of sickness and death among our participants was. These are the locations throughout the United States where programs existed. Again, this is from the MMWR, but Eliza gathered this information. And finally, the breakdown. I'm not sure what the story is in Canada with regards to intranasal versus injectable. We use injectable. Intramuscular, we suggest a 1 cc intramuscular injection as the first installment. And as that gentleman said in Eyes Wide Open, there's a breath, like a baby waking up, a baby being born, or someone having cold water splashed on their face, or as he said, someone who's without oxygen underwater coming to the surface. And it's quite dramatic, and as you all know, there's no downside to speak of from naloxone. If you want to hurt somebody who has an opioid dependence, you can hit them with a bat or a stick, very cheap, available. But naloxone would be a somewhat strange way to prepare to hurt somebody. We have never heard such torture, except at the hands of some physicians years ago in something they used to call the Narcan challenge. But nevertheless, the I think cost is the biggest reason that we use the intramuscular. The kit is quite expensive, and we could probably get close to 40 vials of naloxone out there for what one kit costs, and so that's an important issue. Also, the best data suggests that intranasal is around 90% as effective as injectable. So you can see the growth if you remember the other slide. So there's 50% more programs now in the last 2 or 3 years than there was before. And interestingly enough, just a smaller number of sites, but most of these are programs with that are just starting up. But we're reaching increasing numbers of people, and there's some really profound evidence-based impact of this. If you're familiar with the British Medical Journal article from Alex Wally, Maya Simpkins, and others in Massachusetts, it showed as much as a 46% reduction in overdose fatalities in communities that had adopted naloxone compared to those who hadn't. And then Phil Coffin in San Francisco published a study on cost effectiveness, and it appears to be one almost as cost effective as childhood vaccinations, which is pretty significant. So I want to thank Eliza for letting me use these slides of hers. And just as a side, she loves black licorice. If you know of any good sources of it, I want to send it to her.